We're glad to have all of you joining us today for this exciting webinar. This is Natalie King. I am the Director of Training at ACUFOCUS. We have two great speakers today. They're going to help us guide us through a very important topic, normal and abnormal findings during post-op recovery. And for those of you, that see these post-op patients and wondering what is normal, you're going to love the speakers and what they have to share with you about their many pearls for success today. I just want to advise you that the comments made by the speakers on the webinar are not necessarily those of ACUFOCUS. So I'm so excited to introduce our great speakers for today. Some of you know them already, but from Sandra Black is an optometrist and also the Vice President and Director of Clinical Operations at Crystal Clear Vision in Toronto, Canada. In addition to working in private practice, she's also a very well-known international speaker and author. And of course, she's a KAMRA inlay patient. She's 3 years and counting. So welcome, Sandra. And from Clear Choice Custom LASIK in Cleveland, Ohio, we have Dr. Jeff Augustine, who's the Director of Clinical Operations there. His practice has been offering the KAMRA inlay to patients for, well, a little over a year now, and they have quickly become one of the country's top KAMRA inlay implanters. So please join me in giving them a warm welcome to Dr. Black and Dr. Augustine. We're excited to have them today to share their post-op secrets. And thanks to both of you for joining us. I'll leave it to Dr. Black if you want to get us started. That would be super.
Thanks, Natalie. Thanks for the great introduction. Hopefully we can live up to all the accolades. So what we're going to be going through is your normal post-op care and what you should be seeing and what are your big red flags on your day one, week one, month one, etc., all the way through. So if we go on to the first slide, the first thing that we have to do before we even can think about post-op care is we have to ensure that we have the right patient starting out. And so if we assume that everything is the way it's supposed to be, and that being said, I just want to quickly go through them, you always want your dominant eye to be as close to plano as possible and your non-dominant eye to be somewhere between plano and -75. Obviously, if the majority of patients that walk into your office aren't there, we LASIK them so that they are there. We do refractive surgery to get them to that target. Even if you have a patient who is +1, uncorrected is 20/20 in both eyes, you're still going to want to do LASIK on both their eyes to get rid of that hyperopia. So on the dominant eye, even though it's a 20/20 eye, it will draw the other eye down if you leave it. So you do want to make that as close to plano as possible. And again, the non-dominant eye, somewhere between plano to -75, but ideally around -75. We're dealing with a patient population that they're getting older, their tear film just isn't as good as it used to be. And so you want to make sure they do have a good quality tear film before surgery. We generally put all of our patients on Restasis pre-op, and I always plug everyone on surgery day to make sure that we've got a 3-month collagen plug in there before we go into surgery. If you don't have a good quality tear film before surgery, hold off until you do. Postpone that surgery because that really is going to affect how the patient heals. We use the ACUTARGET HD to measure the quality of their lens. And then you also want to make sure that you are meeting these patients' expectations. If you have a patient that comes in that's -2 myope and they're used to reading without their glasses and you don't give them any preoperative counseling on what to expect after surgery, that they're going to get just good functional vision at all distances, they're going to be comparing their reading without their glasses to that inlay. And while they'll be totally functional with the inlay and they'll be able to cope without glasses and read without glasses, go through their day and be very, very happy, they're still not going to have the same vision as they did without their glasses beforehand. So you really want to make sure that you counsel these patients beforehand on what their expectations are and what the healing process is like. Next slide. So one of the biggest things that we found was having the ACUTARGET in our practice. When we first started nearly 4 years ago, we didn't have the access to the ACUTARGET HD, and you get every patient that comes in your chair in their mid-50s. If you look at them behind the slit lamp and you look at their lens status, they're going to have some mild lens changes. That's normal with age. They can be best corrected to 20/20, but the big question is, are they significant or not? We now have the ACUTARGET HD, which now allows us to measure those patients to make sure that they do have a nice, clear, healthy lens and so that we know that we can move forward with the patient. It gives you a very nicely readable scale. You know, green is good. So just remember, green is good. Anything above that, you're going to want to talk about an RLE as opposed to a corneal procedure. Next slide. We also use the ACUTARGET HD, plus we have a tear lab as well, and we use those together to analyze the patient's tear film before surgery, just to make sure, like I said before, that we do have a good, clear tear film going in. So the biggest thing that we have on our website that is the bane to my existence is that my surgeon, Jeff Machat, had his surgery done by Dr. Tomita 4 years ago in Tokyo. And he was reading the next day. And we have a video of him reading small shampoo bottles and a newspaper on our website, front page, the next day after surgery. So patients come in and they expect that's what's going to happen to them. We tell all of our patients that pre-op, I tell them all that yes, Dr. Machat was reading the next day, but the majority of patients, 80% of patients are like me, and it took me 6 weeks before I was clear. So I tell patients, you are going to have a haze. This is going to be normal. If you're lucky, you'll be part of that 20%, but the majority of patients will be blurry day one. So when the patients come in to see me, I always measure their distance vision monocularly, and I measure their reading vision binocularly, and I get around the 20/40 to 20/50 mark at both distance and near. But the patients are coming in and they'll say to me, I'll say, how are things going? And they'll say, yeah, it's hazy, just like you said. So they understand this is normal because we've counseled them about that pre-op. So you just check your vision and you reassure them. Next slide. If you see this, this is not normal. Like I said, dry eye is the number one problem with patients post-operatively, and you really have to make sure that we maximize this tear film. So if you have not put them on Restasis or you've not had them use drops and you see this kind of SPK, crazy dryness around the inlay, make sure that they're using their drops. Definitely put in a collagen plug. You know, add Restasis if you have to. Put them on omega-3s. Do whatever you can, because that patient is not going to do well. Next. If you see this, if you see any type of folds or a rip in the inlay, and this actually got through surgery, and I saw this post-op, if this gets through surgery, and even though the patient may be happy, if they're seeing well, reading well, this inlay has to be replaced. Okay, any breach in the inlay has to be replaced. It's going to be a wound healing response waiting to happen. By week 1, what you'll see, if you go out to the waiting room before you grab your patient, you go out to the waiting room, you will see them reading. Most of them are on their cell phones, they're doing something up close, and they're reading comfortably, and they probably don't even realize that they're able to do this now where they weren't a week before. So I usually bring that up to them as I'm walking them into my chair. I'll say, hey, look at that, you were reading, isn't this amazing? And what you'll find is the vision is usually improved to about 20/30. Some of them it's a little bit better at both distance and near. And what the patients will notice, and what I noticed myself, I call them moments of clarity, where you'll be functioning in this haze and all of a sudden, oh my God, it's clear, I can see. And then boom, it goes, it disappears again. And they'll get these moments of clarity, and those moments of clarity will get closer and closer together until they're totally functional. Next slide. If the vision hasn't improved, 99.9% of the time it's dry eye. It may be centration, but the majority of times it is dry eye. So really watch that, do the ACUTARGET HD, really be aggressive, like I said, with that dry eye therapy. Next slide. Again, we check it. Okay, we check it on the ACUTARGET, we look at it, we make sure, and I can show them. One of the nice things about the ACUTARGET is you're able to actually show the patient. And you can say to them, see, here's where the problem is. It's this tear film. We really have to work on this to get you seeing well. Next slide. Month 1, the patients are going to come in, they're going to be a lot happier. At this point, they're usually about 20/25 to 20/20. In a normal patient, the slit lamp, everything looks clear and beautiful. They've got a good tear film. The refraction is where you want it to be. But one of the biggest things that happens at this point is that the patients, because they're happy, they stop using the drops. All is good. I don't have to use any more of these crazy steroid drops. I don't have to use any more of these artificial tears. It's really important that you stress that no matter how well they're doing, These drops are important, and they cannot stop. Okay, they have to continue. Next slide. If you're seeing absolutely no improvement in vision, then definitely be a little more critical about your decentration. I know that we say that it's going to be about 300 microns and the patient should be doing quite well, but what you'll find is that if the inlay is decentered superiorly, the patient may notice more problems than if it's decentered inferiorly. So if you have a patient that is not doing well visually and the inlay has a decentration superiorly, even if it's within that 300 microns, that could very easily be the cause of the problem, and you may have to go back in there and recenter that inlay. Okay? If the centration is perfect, then the likelihood is, again, I keep saying it over and over, it's tear film, and if they're not on Restasis, get them on Restasis. The other thing that we always have to remember is there could be some regression there, so check the prescription. Especially if you've done a hyperopic LASIK for that patient, they could be regressing back. They could have lost that minus 0.75. They could be back to plano or slightly hyperopic. And again, that's going to affect their outcome. So you want to check the prescription, make sure they're on target. Next slide. So when you do refract these patients, it is a little bit more difficult because you're dealing with a pinhole, so they have this increased depth of focus. So that in some cases it can be difficult to get a clear endpoint. I find that if I measure the refraction with the lights on, I generally go in half diopter steps. I think I've had a problem once in the 400 inlays that we've done, but you can always use red-green if you have to, or a midpoint refraction. I know that, Jeff, you use the red-green, I think, a little bit more, correct?
Yeah, I use the red-green and find it to be effective. I guess it's I just look for standardization in information gathering when it comes to post-op. So whether you use the midpoint refraction or red-green, I would say stick with one, and that way there's no confusion between when it comes to data gathering. I find red-green simple to use. I put the 20/40 up at distance and just do a spherical refraction. Generally, I start at about a -1 at 1 month post-op and go up and down and titrate accordingly. I'm accustomed to doing red-green anyways with all our LASIK patients and laser vision correction patients that I'm doing workups on. So for me, you know, that comfortability just carried over on the post-op camera refractions.
Awesome, thanks. So it's whatever makes you feel comfortable, but as long as you're refracting them and you're comfortable refracting. And the next slide. Month 3 to 6, again, patients should be happy, cornea should look clear and quiet. It still will get better. I found that my vision even got better up to 2 years. So still want to remind those patients, still stay on the drops, still use their lubrication, don't stop anything.
Another thing that I emphasize throughout that post-op period is, you know, the aberrations that the patients may have at night, especially if you're combining a LASIK procedure with a KAMRA procedure. That may compound the edema, and so a lot of the patients will complain of the halo glare at night for some period of time. But at the 6 months to a year out, I feel that they neuroadapt to it. And also,
well,
you know,
I think what a lot of patients do, unfortunately, is they do what we call the refractive surgery salute, where they compare their eyes. And we always tell our patients, don't you dare do that.
Right, the blend. I like it to blend better than to isolate the eye. There's also, I've had patients complain of in dim illumination, you know, they tend to complain that they can't read as well. And I think that goes across the board, whether you have the KAMRA inlay versus monovision LASIK. I still find that to be a pretty common issue.
Yeah, no, for sure, and it does get better. You will find, I found between year 2 and year 3, I neuro-adapted, and I now can read in dimmer light than I could before, which is amazing. So if at month 3 to month 6, month 3 and month 6, if you're still having difficulty, you've got to look at the refraction. If you're finding that the patient is more myopic than they were before, then that could be one of 2 things. It can be dryness, okay? And again, dryness, like I keep saying over and over and over, dryness is the #1 issue with these patients post-op. Or it could be regression. Again, if you've done LASIK on a patient and they were a high myope, you want to make sure that that prescription hasn't regressed back and they haven't gone back to being more myopic than you expected. And again, if they're more myopic, their distance vision isn't going to be as good. If they have become more hyperopic, it's one of two things. One option is regression, and again, if you have done a hyperopic LASIK, it could very well be that they've gone back, they've regressed back, and that's the issue right there. But it is possible that you're having a corneal wound healing effect. So what you want to do is you want to, number one, look for haze around that inlay. So if you've got a hyperopic shift, you're going to look for haze around the inlay. You're going to look at the topography, and you're going to look for those changes, and those changes will look like a red ring, and I'll show you an example in a second. And you want to manage those patients immediately with steroids. Okay, so if you get this hyperopic shift, you want to take care of it right away. And if you go on to the next slide, you can see what that looks like on topography. You can see that red ring, okay, and that's a really good indication when that patient comes in complaining that they're not reading well, that they've had this hyperopic shift. And if you actually look at the inlay, you can see haze for the most part. Either it can be around the edge of the inlay, it can be right over the top of the inlay. Sometimes it's actually underneath the inlay, and you can actually see that it doesn't look as transparent as it did before. Go on to the next slide. These are just some other shots of corneal haze. So you can see what the appearance is. You can see some of them are worse than others. The one thing I tell patients is to really monitor their vision. If they start to actively find a major change in vision or something's wrong, to come in and call the clinic and get in rather quickly, because with the haze, if you can treat that aggressively early on rather than have the patient wait till they come in, they'll wait and wait and wait. I just tell them, if you're finding a sudden vision change, immediately come into the center for a follow-up. Yeah, 100%. And we found that the majority of our patients that have developed haze, it's because they've stopped their drops. When you actually question them, they stop their drops as soon as they were feeling good. So what we do is we put patients, we go very aggressive. We put them on Predfort QID for 2 weeks, and then we see them back. In about 50% of the cases, you'll find that the refraction will go right back to where you want it to be, and the haze will start to clear up, and they'll be much, much happier. In some cases, as long as, even if it's going in the right direction, even if it's not 100% there, but it's going in the right direction, then we will still keep them on the steroids, and we do that regardless. We then switch it down to Predfort twice a day. We see it for 2 weeks, and then we see them back yet again. If everything is still stable, still in the right direction, then we switch them over to a weaker steroid. We do a taper from QID down to QD over a 2-month period, and then we check them yet again. And then we keep on that Lotamax or FML, and we actually go for every other day for 2 weeks, and then every week, 1 drop a week for 3 months, and recheck them then. And we could continue that for an additional 3 months. And we find that will keep everything under control. If after the first 2 weeks you see absolutely no change in the refraction, they're still hyperopic, the haze is still there, there is no change in anything, then at that point that's where we'll consider removal. Next slide. At year 1, again, this should be your normal, stable, happy patient. And like Jeff said, and I said earlier, that the patients at this point are going to start to notice that they're going to find it's going to be a little bit easier in dim lighting. I definitely have noticed some neuroadaptation on my own that I can now read in dim restaurants on these menus that are beige on brown that I couldn't read before. And so all the patients will start to notice that as well, and I'll tell them that that will happen. But regardless, all they need if they can't read in the dim restaurant is a little extra light. They don't need reading glasses, they just need some extra light. And the next slide. If at year 1 they're not happy, the vision has reduced at this point, it's one of 2 things. It's that haze, and Eric is going to go through this in a lot more detail at the next webinar with that hyperopic shift, or it can be lens changes. We've had 2 patients that have developed cataracts a year or 2 after we've put in the inlay. They had a nice clear lens to start, and just because of their age, they did develop cataracts. And so don't miss the forest for the trees. Check out the lens to make sure. You can use the AccuTarget to check their OSI, and you can check the scatter and take a look at that lens. Next slide. If they do develop cataracts, you've got some options. You can just do you can leave the inlay in place. You can do a manual capsulorhexis, put in a monofocal IOL with a target of about -75, and they'll still get all the benefits of that inlay afterwards. You can remove the inlay, do your cataract surgery, and then replace it after surgery, and again, targeting -75 with your monofocal IOL, or you can remove it and put in a multifocal IOL. We've actually done the 2 patients that developed cataracts. We've done the 2 top options. One of them we left the inlay in place and just did her surgery, and the other one we removed it and then put it back in again. 2 different surgeons. It was just their comfort level, and they both have done really, really well. And the next slide. And just to make sure, whenever you're looking at topography, when you're looking for these red rings, make sure you've got proper diagnostics. This is the exact same patient done on 2 different topography devices. On the left is the orb scan. We have the Schwinn laser on the right, and that's the topography unit that we use. And you can see that if you're using an orb scan, it's going to look completely off. It's going to look like that patient is just ectasia waiting to happen, or ectasia that has happened. So make sure you've got proper diagnostics in your surgery center. Thanks. And now we're switching over to Jeff, and you're taking over on a case study.
All right, just a couple pearls in regards to what Sandra was talking about. I also keep a record of each of the patients on a spreadsheet so that I'm able to track patients that don't come into the clinic. I'll have a good idea if they've missed an appointment. I red flag them so that they don't miss an appointment, and so I don't want them to go unseen and then have a problem. So I go out of my way to coddle this particular surgical population. So that's a couple caveats in regards to Sandra's talk. Also, one other one that I was thinking about in regards to the cataract formation is that you have to kind of look at the KAMRA inlay structure in itself, because you're looking through a 1.6 millimeter aperture. So any mild opacification on the lens can have a great impact. So a subtle PSC may have a greater impact on visual acuity because of the inlay. And I want to be certain that we don't think that it's the inlay that's causing the problem and inadvertently take the inlay out when it happens to be a cataract-related issue. So really scrutinize the lens in detail with the use of the AccuTarget and also a very good slit lamp. Okay, so we'll continue on here. I work with 2 surgeons. The surgeons that I work with is Dr. Bill Wiley and Dr. Shamik Bafna. And we've done about 156 of the KAMRA inlays over the past year with great success. But again, early on, I have to say that I may have made not great clinical decisions in regards to candidacy, but through the practice and learning, I've developed a better idea as to how to have great success with these patients. And this was an early case that we had worked with. And I'll go through it quickly, and Sandra, you could chime in at any time for red flags. So I'll walk you through this. This 52-year-old female came in. She did not go into the details, and I didn't explore the deep into the medical history of her. But later, at her 1 to 2 weeks out, I found out that she had fibromyalgia and gluten sensitivity. So,
red flag.
Red flag. The pitfall on my part was that I now have to go into the intrinsic nature of exploring the medical aspects of these patients. And I think during the pre-ops, I'm asking them a lot of questions about their medical history, making sure they don't have collagen vascular disease, making sure no scleroderma, no rheumatoid arthritis, no diabetes, no fibromyalgia. So that was the one big red flag on this first slide. The other thing that you'll also notice is that, you know, the eye that we're going to operate on is going to be her right eye. And as Sandra pointed out in her earlier preoperative analysis, she'd like to see the patient at plano to -75. And in this case here, you see that her cyclo was +1/4. So retrospectively on this patient, I would probably optimize this patient by having LASIK and create a -1 to a -75 on that operated eye. Pachymetry looks good. Next slide. And you can see this slide here. This is the heart and lung of managing KAMRA patients. This is like the topographer is for LASIK, because with this, you're able to plan centration. You look at the objective scatter index as it relates to the lens, the assessment of tear film. And this instrument is utilized both preoperatively and extensively postoperatively so that you get better screen patients that are going into surgery and better manage patients postoperatively. Next slide. And here's the patient's diagnostics. We find that the patient's cord length is 97 microns. The Purkinje is located inferior temporal, and she doesn't have an issue with the tears. Her ocular surface looks really good, and she's got a very pure optical system, meaning I got her to 2020, 2015 levels, and that's going to be key to your success. You know, a patient comes in that may be 2025, you're thinking, oh, you know, well, 2025, that's going to be okay. Well, really, you really want to have the most pure optics possible, both eyes, in order for this to be successful. Don't compromise on a patient that may be 2025, 2030, because the success rate with that is not going to be that dramatic. Again, this is going to be, we can move on to the next slide. We're going to see how this patient did as far as surgically. It was unremarkable. At 1 week out, or at 1 day out, I didn't see anything that was abnormal. The centration was good. Visual acuities were what I expected at day 1 post-op. But at 1 week, the patient actually came in earlier with extreme photophobia, almost like a transient light sensitivity. Patient had her sunglasses on, even in the exam room. I looked in, I saw mild corneal edema, no issues on centration. I had the patient on Pred Forte, QID for that first week, but decided to go with the stronger steroids, so I went with Durezol 4 times a day. Her distance vision was very good, but her near vision was still at 2100. So I said, come back and see me in a week, because I'm always worried about glaucoma as it relates to the strong steroid Durezol, and sure enough, she did have an elevation in pressure. Her manifest refraction was +75, best corrected now at 20/25. Visual acuities were comparable to the 1 week at 2100 near and 2015 distance. So then I went and instituted Comigan to help control the interocular pressure. Next slide, please. So I went through the diagnostics again with the HD system, looking at, again, centration. And then I found out at 6 weeks post-op, she's starting to increase on the OSI standpoint, and I attributed that to ocular surface issues. So then I instituted Restasis. Next slide, please. And again, this goes back to hydration compliance. At that 6-week mark, I did go back and explore the issue of whether the inlay was at the proper depth. And we had set the depth of this inlay at 260 microns. And with this corneal OCT, if you look at some of the numbers, you look at this inlay may be placed at a little bit shallower than expected. And again, keep in mind this is a primary case and no previous LASIK. So at 6 weeks post-op, I'm starting to see the manifest refraction migrate towards hyperopia. I did go to a milder steroid, the FML, because I had her on that Durezol for an extended period of time, tapering it down, but I felt at this point it would be okay to go to the milder steroid. Her sensitivity to light had diminished. Next slide, please. But again, I started Restasis at the 6-week mark. And we go back to hydration is key. Tear film is critically important. If you look at the dynamics and the structure of where the inlay is located, it's located at the apex of the cornea. You're looking through a 1.6 millimeter aperture. So any compromise in regards to tear film and ocular surface will manifest itself in poor vision. So Sandra uses Restasis. I have used Restasis, but I don't use it on all patients. I kind of look at what their pre-op is. If they're going to have LASIK or a primary, that may be an indication also. If they're going to just do a primary pocket with a good tear film preoperatively, I may not go down the road of Restasis. On all female patients, I do use Restasis or Xiidra. Punctal plugs are put in immediately post-surgery, so Dr. Wiley or Bafna puts those in. And omega-3s are also a nice adjunct as well. So I guess in my standpoint, I kind of assess what they are preoperatively, and I get the patients on it ahead of time. And then postoperatively, if it's indicated, I'll use it postoperatively when it's necessary. There are some patients that don't require this, but the majority of patients do require this because of where the inlay is located, and again, the ocular surface is really paramount. Next slide, please. This is the ARC scan, and fortunately, I have an ARC scan. What this is an immersion ultrasound, and what I was looking for on this patient was to see if there was any type of an inflammatory response below the inlay that I was not seeing on top of the inlay. So what I'm looking for is a little bit of haze underneath it that I'm not being able to pick up on slit lamp. In this case, I was not able to appreciate it. But again, I was also, the ARC scan is telling me a little bit about the depth, and I was able to go back and compare that to the OCT. And it looks as if this inlay is sitting at about 220 microns. We had projected to put it in at 260. And it goes to show you that the more anterior the placement of the inlay, the more inflammation is in that area, because there's more keratocytes in the anterior cornea than posterior cornea. And some of our earlier cases that we had done, we had actually put in some inlays at about 200 microns, and now we're putting them in, looking at the safety net, at about 275 microns. Sandra, you have comments on that?
We go, the minimum we'll go is 250, minimum.
The minimum.
I know in the early days we were told 200, but we were also in the days of using thick flaps, so we do 250, 280 on a regular basis.
And in doing so, that's cut back on the inflammatory response, correct?
Oh, for sure. Plus our long steroid regime.
Right. Next slide, please. So again, I'm at the 4-month post-op, and you can see what's happening. What's happening is this patient is continuing to shift towards hyperopia. Her uncorrected near vision is 20/80. Her tear film did improve with the Restasis, and I've continued to monitor this, but I'm very concerned. And at this point, I plant the seed that I believe, she's asking me what's going on, and I'm trying to give her answers. I'm trying to run a lot of diagnostic tests. I'm looking at topography. I'm looking at pachymetry. I'm trying to see an inflammatory response causing a hyperopic shift, and that's what's happening. But again, I'm in a quandary, because should I go back to Durezol and go back to the risk of glaucoma, or should I continue with the FML? So those are some clinical decisions that I'm having at this point. But I also plant the seed with her at this juncture that if she continues with this healing response, that the inlay is going to be probably explanted. And at 5 months out, she's continuing to migrate towards hyperopia. You can see that she's at 20/25, 20, or at +2.25 now. And we're starting to see a thickening on the pachymetry. So the top topography there, her pre-op was 587 microns. Post-op now at 5 months, she's at 600 microns. So you're starting to see some thickening of the cornea, which is causing that hyperopic shift, which is most likely below the inlay. So next slide, please. So some final thoughts here. what's the cause of the refractive error shift? What's the next step in regards to medical or surgical therapy? So I'm going to have Sandra answer these questions.
Well, I'll tell you, first of all, and even though I said to you red flag fibromyalgia,
yes.
At the beginning, we made the same mistake in our first group too. We did one patient with fibromyalgia and we ended up taking it out. I'm impressed at how far you actually went. We would have taken it out much quicker as that inlay was just progressing further and further. That refraction was just getting more and more hyperopic. We would have had that thing out a lot sooner. But it's an inflammatory response. It's a wound healing response. And like I said, I would have gotten that thing out fast.
Yeah, I think I learned quite a bit of, as far as in this particular case, I retrospectively, I looked at the shallowness of where the inlay was placed. I looked at the medical history. I looked at the wound healing response. And also I now go in, when I do a pre-op, I emphasize the fact that, your body may respond to this in different ways. We have medical abilities to control your responses, but in some cases, if we don't reach the goals and we feel that it's necessary, we will remove it, and it is reversible. And so that was my journey on. I've only had, out of the 156 inlays that I've worked with, I've only had 2 explants, and this one was in result of a healing response. My other one was in regards to expectations, and again, this was one of our first 20 cases, and so I went through kind of the learning curve. So hopefully these pearls in this particular case will help shed light for you in your practices, and so you can make better medical and surgical decisions, and so it improves your outcomes. And that's my final thoughts on that. Next slide, please.
And I think, do we have any questions, by the way? If there's any questions, please make sure you submit them.
And so this is a nice videotape that I'd like to show you on the explant itself. And the reason I'm showing this video, can we go back to the video, is because I want to show you the simplicity of the surgical procedure to actually remove the inlay. And in this case, Dr. Wiley's going back where the tunnel pocket was made. He'll open that, taking very meticulous care not to disrupt the epithelium, certainly to avoid epi-ingrowth. Now he's going in and breaking the chads both inferiorly and superiorly on the inlay. The inlay is slippery on top and has like a Velcro mechanism on the bottom. And now he's going in and slowly bringing the inlay out. You can see the inlay is rather tough. That's one thing I appreciated on this particular slide, or this particular video. It's made of the same material as the interocular lens haptics. And you can see the video stop, but he's going to reach in with some forceps here and just grab the tip of the inlay and remove it. He then pulls the inlay out, examines it to make sure there's been no remnants or breaks or tears that has left the inlay inadvertently in the cornea. This patient was put on antibiotic steroids post-op for a week. As far as her getting her back to her, she returned to her uncorrected vision. This was the patient that was the +2.25 that we talked about earlier. And again, she went back to plano within 1 week post-op. And there is no real evidence of the fact that she had the inlay in. And so that's kind of the magic of these inlays and the fact that they are reversible. Globally, there's a 1.2% explant rate, and that's for the pocket tunnel-based procedure. It's visual expectations, visual symptoms, halo glare, neural adaptation, and healing responses are the major reasons for inlay removal. Next slide, please. And again, these are when I do a post-operative exam, this is what I'm looking for, and I'm looking for standardization so that every time I see a patient that has had an inlay, I'm going back and I have my technical staff understand how to set the room plate, how to put where to put the near point cards. And so this way, everything is the same each time I visit with the patient. So I look at uncorrected near, uncorrected distance. I do the refraction at 1 month, every time looking at the slit lamp, assessing edema, objective scatter index, tear film index. My centration, I really look at centration at the 1 week and at the 1 month, and I do topography at the 1 month, 3 month, looking for the red ring, blue ring, as well as any thicknesses and changes that are going on. I also do the ARC scan at the 1 month check, and I do that at their pre-op as well now. So again, here's your checklist for complications. And Sandra had indicated in 99.9% of cases, it's going to be dry eye. The ocular surface has to be pristine. Centration, again, has more impact when it's superior, and that can be rechecked on the ACUTARGET. Again, a subtle cataract may have dramatic impacts. Don't be confused between the cataract causing the visual loss versus the inlay. Again, in my case, we saw stromal thickening, wound healing response, the red ring, thickening on the topography, looking for haze on the inlay, jumping on that quickly with a steroid, and then also understanding the fellow eye in regards to refractive error. Let's say the fellow eye that did not have LASIK is a +1. As Sandra had indicated, it's going to be very important to do the hyperopic LASIK on that dominant eye because of latent hyperopia and accommodation issues. So that concludes my talk on abnormalities, and Sandra did a fabulous job on the normal, and so I think in summary, it's going to be really important to coddle these patients, make them understand that if there's any subtle changes, not to hesitate to come in. I've had 2 patients, come in with a little bit of haze formation sectorally, not much of a refractive error change, but I was able to address it quickly and get them on the steroids to not have that escalate into an issue. I think that's the go-away take-home message.
Great job. Thank you very much, Jeff and Sandra. For those of you on the webinar, the contact information for both Jeff and Sandra are right there in front of you. So if you want to contact them, they would love to hear your questions, and either by email or phone. We had some great questions come in, so in the next few minutes we'll go through some of the questions that you sent in during the webinar. So thank you very much for that. Jeff, the first question is for you. One question was about the case that you were talking about. It's multifactorial, so I'll state the question, and then I can state it again if you want more clarification. So the person wants to know, why was the cornea thickening, and did it go back to normal after removal, and how long did it take for the vision to fully recover after removal for this patient?
Okay, to address why it was thickening, the reason why it was thickening is the patient was having a keratocyte reaction to the inlay, and because I was not controlling it with a strong steroid and a weaker steroid, we saw the area, that particular area, thicken up. Oh, when did she go back to baseline? The patient recovered fully. Remember, she was at 2 1/4. At 1 month post-op, off all drops except for some artificial tears. She was plano, 20/20 at distance, and gone back to her normal uncorrected near vision. She went back to +2, I gave her a +2 1/4 spheres as far as her reading glasses go. So she did recover fully without any vision loss. There was a slight stromal haze, but had no impact on visual acuity.
Great, thank you, Jeff, very much. Another question that we had came in is, there's Excedra out there, and there's Restasis. Is it okay to use both of them and together?
You know what? That's a good question. I have not used them in combination with one another, but based on the how the vehicle actually works, the Restasis can take longer for it to work. Xiidra takes a little shorter time to work. I have a handful of patients on Xiidra right now. My colleague, Dr. Tom Chester, he has utilized both Restasis and Xiidra in combination, and he would I would have to go to him and kind of ask him what his clinical impressions are in regards to combining that. But I have not had any clinical experience with the use of combining both those medications.
Thanks. How about you, Sandra? Have you had any experience with combining both of those?
We're approved in advance of you guys for everything except for Xiidra. We do not have Xiidra approved in Canada yet. But from what I've been told, it's one or the other. I've been told that a lot of patients will try Restasis. If the Restasis doesn't work, they try Xiidra, or vice versa. But I haven't heard anybody use them in conjunction.
Great, thanks. Another question from the audience is the Penacam a good diagnostic test for pre and post-op? We don't have the ACUTARGET in the office, in this office.
What are you trying to determine with that? It's great for post-op. It's great for pre-op to check, the corneal integrity, the health, the thickness, everything else, and for post-op to take a look to be able to see if there's any of the red rings or any issues. But it's not going to really help with the ocular scatter or the tear film, as far as I know. Nothing that unless they've got some new upgrade to it that I know nothing about.
Yeah, that's all we have on that question. So I think that was more geared towards around what the Penacam would do as a diagnostic. So thank you for that. And I think as long as we're on that same subject, there's another question about topography findings as well. Is the best method, and I'll direct this one to you, Sandra, at first, for topography, only the axial map, or can they use other kind of topographers like Penacams as well?
They can use, even a Humphreys will work. You can use any of the topographers to get a decent map to be able to check if you're looking for post-op for any of the red ring or the blue ring if it's dryness. They will all work. It's just the orb scan that has a real problem.
Okay. So speaking of the red ring and blue ring, we did have another question in the Clinical Pearls booklets, it talks about seeing the blue ring and the red ring. Can you clarify what the two indicate again?
So the red ring, you're looking at generally a wound healing response, a hyperopic shift. The blue ring is generally a dryness issue. I know from our standpoint, I can see a patient that's extremely dry. I don't see the blue ring on topography. I will see a red ring without a problem, but a blue ring doesn't seem to show up on our topographer. I don't know, Jeff, do you ever see that blue ring?
I use a transaxial view, and I do see. I also have to look at, when I'm looking at blue ring, red ring, I have to look at what we had done preoperatively on the refractive error, because a lot of times I can be confused with, let's say, a hyperopic LASIK patient where we steepen the cornea and expect to see the red, and then we take a myope where we create an oblate cornea and we see a blue pitted area as well. So a lot of times I look at it. I put probably more emphasis on the ACUTARGET diagnostics system in regards to tear analysis than sometimes being confused with the red and blue ring. I do look at the red ring a little bit more now in regards to healing response. But I put everything together from a diagnostic tool standpoint before kind of making a decision as to what the etiology of the problem is. But again, it goes back to what...
So that's probably the number one thing that you just said right there, is that you've got to put all the findings together. It's never just one diagnostic test that's going to give you the answer.
Right, but then you go back, what you said earlier, 99.9% of the time, it's going to be ocular tear film. It's going to be a tear issue. If you start seeing that hyperopic shift in regards to in regards to what the visual acuities are doing, what regards to your refractive error changes that are going, then obviously that's going to lead you down the road of thinking more of a healing response. So it all goes into one big soup in order for you to get a good taste of where you're going.
Well, thank you. We have about enough time, I think, for one more question. And one of the questions was, my surgeon uses Durasol instead of Pred Forte. Will that be a problem? Jeff, could you take that first?
Yeah, I'm not a big advocate of Durasol because of the glaucoma response being as high as it is. Also, cost-wise, it's probably much more costly to the patient, and I have just been a strong advocate of using Pred Forte. My typical regimen is going to be Pred Forte, tapering 4-3-2-1 for the first month, and then going into a milder steroid on a longer period of time. But again, the only in regards to my Durasol usage, I'm having to use the Durasol in regards to managing the raindrop, because the raindrop is much more anterior than the inlay is with the KAMRA. And so in that case, I have to go to a stronger steroid, which I'm not a strong advocate of it, but in those particular cases, I'm having to do that.
Sandra, do you have anything different on that?
Yeah, we don't use Durasol at all. We use Pred Forte as our strong steroid 100% of the time.
Okay. Well, super. Well, we do have a few more questions, but with the time running short, we're going to wrap it up right now. So thank you, both of you, for your time and your pearls. It was wonderful. And thanks all of you for joining us today. We hope that you really found it valuable. Don't forget that to join us for our next clinical webinar, it's Tuesday, December 6th, same time, same place. So stay tuned, and we'll send you an email for the next announcement and the link also to view this webinar. So good day, everyone, and thank you very much. We'll hope to see you soon.